Recording now.
So we are on live.
Thank you, Ravinda. Friends, welcome to the Spine Wellness and Care Foundation's webinar. Today, the webinar is on spinal infections. I'm glad to inform you that the webinar is being organized in collaboration with Sri Balaji Action Medical Institute. And we have a very esteemed panel for the webinar today, the best experts from across the globe. Before we start, may I request all those who are not speaking to keep their devices on mute. This would be other than our esteemed panelists who can keep their devices on throughout the webinar. We will have the webinar discussion before, and we will have questions and answers from the participants at the end of the webinar session. Though if there are any burning questions, please keep typing them in the chat box and we'll try to get back to you either within the webinar or at the end of it. Other than the Zoom, the webinar is being telecast live on Facebook and also on the Sabami network. So welcome once again. Today's topic is very important and important to create awareness. We know that spinal infections is an age-old problem, is an ancient entity with some descriptions even in the Iron Age. It was observed in mummies from Egypt and Peru as far as 9000 BC and described as Yakshama in Charaka Samhita and Sushruta Samhita. In 1779 itself, Sir Percival Pott described tubercular spondylitis or tubercular infection of the spine and its clinical presentation of paralysis. We know that spine is susceptible to infection, accounting for 2 to 7% of all cases of musculoskeletal infections. The incidence could be 1 per 100,000 to 1 per 250,000 in developed countries, but it is far more in emerging countries. Spinal tuberculosis is also important, especially in emerging countries like India. Overall, if you see, there are about 24.2 lakh cases of tuberculosis which were notified in 2022. Pulmonary tuberculosis, of course, is the most common site of involvement, but extrapulmonary tuberculosis is seen in 3 to 15% of pulmonary tuberculosis. And skeletal tuberculosis is 10% of extrapulmonary tuberculosis. The spinal tuberculosis is 50%, is seen in 50% of skeletal tuberculosis. So if you see overall, spinal tuberculosis poses a major challenge, especially in emerging countries like India. If you see the epidemiology, there is a bimodal distribution with a peak below 20 years and another between 50 and 70 years of age. There is a 2:1 to 5:1 male is to female ratio. That is, men are more predisposed than female towards spinal infections. Spinal infections knowledge is important because it is a serious disease which can result in neurological complications and has a potentially high morbidity and mortality. The symptoms associated with neurological deficits such as leg weakness, numbness, and incontinence are present in about 1/3 of patients. And there's a frequent association of pyogenic vertebral osteomyelitis and infectious endocarditis. That is, it is seen in up to as many as 30% of patients. So it's not only the spinal infection, but the associated infections which can play havoc with the patients. And in many developing countries, particularly in Southeast Asia and Africa, spinal infection is a very common cause of non-traumatic spinal cord injury. The non-specific clinical presentation of spinal infections makes it a major diagnostic and treatment dilemma. Literature reports a delay of 2 to 6 months between the first symptoms and diagnosis, leading to catastrophic outcomes in some cases. And for the management of spinal infections, you generally need a multidisciplinary approach involving spine surgeons, radiologists, and physicians, which could be infectious disease specialists where available. Now, also important is the fact that estimated mortality rate even of date ranges between 2 to 4%. But when it comes to some forms of spinal infections like spinal epidural abscesses, the mortality rate ranges between 13 to 16%. So that is important. It's also important to know that timely treatment is very important in management of spinal infections. It has brought down mortality to less than 5% by preventing the spread of infection to other parts of the body. High clinical suspicion remains the centerpiece of a prompt diagnosis. Early treatment is necessary, especially when associated with factors that may lead to poor outcomes, such as neurological deficit, for more than 36 hours. Also, proper treatment is very important. We will learn later that multi-drug resistant spinal infections are on the increase, primarily due to improper treatment and non-compliance by patients. Inappropriate or incorrect use of antimicrobial drugs or use of ineffective formulations of drugs, such as poor quality medicines or bad storage conditions, and premature treatment interruption can cause drug resistance. Friends, other than the potential morbidity and mortality posed by spinal infections, unfortunately, spinal infections are also on the increase. An increased incidence in recent years due to increase in susceptible populations, particularly history of previous spine surgery, has been seen. The ever-increasing incidence of chronic debilitating medical diseases and HIV-affected individuals further portend to the resurgence of tuberculosis. Realizing the importance of the topic and the importance of creating awareness on spinal infections, especially its timely and proper treatment, and knowledge amongst the community to participate in the treatment, we thought about having this topic as the webinar for the day. And friends, we have some of the best experts from across the globe for this webinar. Introducing Professor ANIL JAIN, Director Professor, ex-Principal, ex-Dean, FMS University of Delhi, from the University College of Medical Sciences and GTB Hospital. Vast knowledge, vast scientific publications, in fact, 147 publications in Index Journal with an H-index of 38, with especially more than 50 articles on tuberculosis of the spine specifically. He was an expert member in committees, participated as team lead for Bone and Joint Group Index TB guidelines in 2016, was the expert for selection of faculty members for various state medical colleges, AIIMS, Bhopal, PGI, etc. He is listed as among the top 2% scientists from India in an independent study by Stanford University. He is the editor-in-chief of Annals of National Academy of Medical Sciences, Indian Spine Journal, and a past editor of Indian Journal of Orthopedics. He has also been the president of Indian Orthopedic Association. Welcome, Professor ANIL JAIN. We also have with us another very dynamic panelist, Dr. KSHITIJ Chaudhary, who's a consultant spine surgeon with PD Hinduja Hospital, Mahim and Khar, Mumbai, with a 15-year experience and with 50+ publications and book chapters, with a special interest other than spinal infections on pediatric spinal deformity and cervical and craniovertebral spine surgery. He's done his training from KM Hospital, where he's an assistant professor now. He's been a Dr. John H. Moe Fellow in Minneapolis and also Harvard Combined Residency Program Fellow in Boston. So welcome, Dr. KSHITIJ Chaudhary also. So we will start the discussions on the webinar with posing the first question to Professor Anil Jain. Professor Anil Jain, what are the causes of spinal infections? Why are they classified separately? Over to you, Professor Anil Jain.
Thanks, Dr. Chhabra, for generous introduction. I think spinal infections and spinal tuberculosis, all spinal infections, there is a wide variety of the causation. It could be caused by the pyogenic bacteria, so they are called bacterial spinal infections, or it could be a little grumbling infections of some other kind of bacteria as Mycobacterium tuberculosis. It could be a brucellar, which is little uncommon, but yes, in certain endemic area, you can still get it, and rarely a fungal spine infections. And it is important that we classify the disease while making a diagnosis into one of the type, because ultimately the objective of treatment is the progression of disease and symptomatology of disease is different in all of these patients, and we have to reach to the diagnosis so that we are able to reach to the bug which we are going to cause causing the disease, and we have to treat effectively medically each bug separately, differently, and that is why it is important that we classify these spinal infection in terms of causations, which organism has caused it. And that is why it becomes important. Well, there are various other classifications we also use, that which part of the spine is affected. It is the body, which is a vertebral body, the bone per se is affected, or it's the disc is affected, or both are affected, or maybe along with it, a spinal canal is also affected, or maybe neck part of the spine is affected, or chest part of the spine is affected, or the lower back part of the spine affected, because these all disease causes damage, mechanical damage, bone damage, and as a result, some certain repercussions as far as the stability of the spine is concerned, and subsequent progression of disease in terms of spinal deformity, in terms of neural deficit or paraplegia or neural loss. So we need to really classify the disease into which organism has caused it and which segment is being affected and what is the extent of the disease being affected. Then we have to take remedial steps, treatment steps for all. And that is why it's important that we understand that what the causation of the disease.
Thank you, Professor Anil Jain. You have described that wonderfully. We'll come to Dr. KSHITIJ Chaudhary, but briefly capitulating, you mentioned that the causative organisms can be bacterial, fungal, or tubercular, and it's very important to distinguish because they have different presentations and they have different management. Dr. KSHITIJ, if you would have anything to add to that, and also specifically asking you, what is the most common organism causing spinal infections? Over to you, Dr. KSHITIJ Chaudhary.
Thank you, Dr. CHHABRA, for having me. I hope I am audible, but the most common organism, it depends on where you live, right? So if you are in a country like India, an endemic country for Mycobacterium tuberculosis, then by far majority of the infections that you are going to see in the spine are because of tuberculosis. The same is not true for Western countries or developed nations, so-called developed nations, where you would find the incidence of tuberculosis to be less. But countries like ours and like maybe Russia, China, these countries will have a much higher incidence of tuberculosis. So the most common organism in those cases would be Mycobacterium tuberculosis. We can't hear you, Dr. CHHABRA. And then there are other organisms as well as the, like, you know, like our relatively the population in India is young, but as the population gets older and then we have more elderly people and more people who have chronic diseases, kidney patients and diabetics and elderly people who are immunocompromised, there the incidence of pyogenic bacteria, which are a more aggressive and fast growing bacteria, that numbers increase in that kind of population. But by far the most common cause of infections in our country will be tuberculosis, whereas in industrial countries, and as you have mentioned on the slide, United States and Europe, the cause is going to be pyogenic infection such as Staphylococcus aureus.
Thank you, Dr. Kshitij, for bringing that out beautifully. So, pyogenic bacteria infections may be the most common cause in the developed countries, but in India, we have spinal tuberculosis, which is largely responsible, and this is true also in other emerging countries. So I will pose this question to Dr. Anil Jain. Professor Jain, what is multi-drug resistant spinal infection and what is its importance?
I think as we all know that whenever a drug is invented and it comes in contact with the bacteria also develop certain changes within their within them to fight against that drug, and that is the natural tendency of developing the drug resistance, and that becomes more important when we do not use these drugs rationally. So we don't give these drugs in the reasonable quantity for reasonable length of time with reasonable indication, and that is why the chance we create an environment where bacteria develop drug resistance to certain drugs. Now you can imagine a situation where the person has a tubercular infection in the body, and you have diagnosed it well, and you have started treatment, and the drug which are being prescribed as a drugs or protocol drugs to treat mycobacterium is not being affected by on the bacteria, is not effective, and bacteria is not responding to it, is not being killed by the drug, and that is why the bacteria continues, that destruction continues, disease process continues unabated. So you can understand how serious that becomes situation. Now this situation even now coming up for pyogenic, because of irrational use of pyogenic drugs, sometime we do detect that whenever a deep-seated infection, we prove that it is a pyogenic bacteria, and we find that bacteria is resistant to half of the drugs or most of the drugs. So this is a day where the antibiotics against pyogenic bacteria or ATT drugs against tubercular bacteria, and for that matter, against any infective organism is not effective. And that is what is called drug resistance. And when there are more than one bacteria is not responding to more than one drug, then it becomes a multi-drug resistance disease.
Thank you, Professor Anil Jain. You have described that very well. Just to recapitulate, when it comes to spinal tuberculosis, multi-drug resistant tuberculosis is that which is resistant to the drugs INH and rifampicin. Primarily, it occurs because of improper treatment, but resistant strains can also be communicable. Improper treatment could be due to suboptimal dose or duration of treatment, especially when patients interrupt the treatment prematurely, and that is a very common cause in our emerging countries. So that is all the more important that people have the knowledge that they are equally responsible for their treatment. And it is important to be aware that Indian government survey from 2014 to 2016 estimated the incidence of multi-drug resistant tuberculosis as 2.84% in new cases and 11.6% amongst previously treated patients. So unfortunately, India, China and Russia together contribute to around 47% of the global burden of multi-drug resistant spinal tuberculosis as per WHO. And thus it becomes all the more important for us to be aware on, about this and how to prevent it. So in a patient with spinal tuberculosis who has been on anti-tubercular treatment for at least 5 months, resistance should be suspected in the presence of poor clinical and radiological response, the appearance of a new tubercular lesion, worsening of spinal deformity, formation of discharging sinus, or dehiscence of the previous scar of surgery for spinal tuberculosis. So it is very important that we retain a high index of suspicion in order to diagnose this early and treat it appropriately. Now, Dr. Kshitij Chaudhary, how does the infection spread to the spine? We are aware that the pulmonary tuberculosis is the most common cause, but how does it spread to the spine?
Yeah, that's a very good question. Actually, there's a common misconception about spinal tuberculosis that spinal tuberculosis can spread from one person to the other, but that generally cannot happen because the mode of communication for tuberculosis is aerosol related. So unless you have pulmonary tuberculosis and you have coughing out the bacteria, you cannot give it to another person. Then how does one develop spinal tuberculosis? That generally happens when a person has already been infected with the tuberculous bacteria, either in childhood or in early adulthood, because these bacteria are in the air. They are in an endemic country like ours. These infections happen in early part of life. And when I mean infection, you don't need to have pulmonary tuberculosis. That bacteria just goes and lodges itself in the lung and lies dormant there. It doesn't cause disease. And that is what is called as Ghon's focus. And most of us have that infection in childhood, and it just lies dormant there. And it stays there until a point in time where it breaks up out, maybe because of, either some stress or some low immunity to that person, and it breaks out, and then it can spread from the lung via the blood vessels and lodge itself into the spine and then multiply there where it will cause disease. So it is important to differentiate between the infection and the infection causing disease, and not necessarily all pulmonary infections will cause pulmonary disease, which will also lead to spinal tuberculosis and disease. And the point of entry generally for tuberculosis is either going to be the lungs or it is going to be the gut, right? But most commonly the lungs. So when you inhale this bacteria, they lodge itself in the lung, they lie dormant in the body, and then maybe at a later part in life, when your immunity is low, they break out, travel via the blood vessels and reach the spine. So a spinal tuberculosis patient who doesn't have an active pulmonary infection is not someone who can give this disease to his family members or to another person.
Thank you, Dr. Kshitij. You have answered to Dr. Komal Kamra's earlier question in the chat box. What is the point of entry? You mentioned that it is most often through the lungs, and it may lie dormant there and may be reactivated at any point subsequently per se. And so I think Dr. Komal Kamra, your question has been answered well. The origin of infection, as pointed out, could be from infection anywhere in the body through the hematogenous route, that is through the bloodstream. It could be a continuous spread from adjacent structures, though this is less often, but it could be also direct inoculation due to trauma or surgery. So that is also common. So I would want to point out that post-surgical spine infections are also emerging as a major challenge, and the incidence, though reported, is highly variable, 0.6% to 18%. Simple disc surgery, the incidence is 0.6 to 3%, but if you add implants to it, then the incidence increase is reported to be between 6 to 18%. the highest incidence of spinal infections has been seen with posterior neck surgery, right? Where this is higher than posterior lumbar spine surgery or anterior spinal surgery per se. And so these are the statistics with regard to the spread of infection. This becomes the post-surgical spine infection becomes all the more important because it places the patient at risk of pseudarthrosis, or what you may call as a false joint, chronic pain, return to operating room may be required. There may be adverse neurological sequelae, and all this results in worsened long-term outcomes. So my next question is to Professor Anil Jain. Professor Anil Jain, what are the risk factors for developing spinal infection?
I think we have to put this question in little, take this separate from the pyogenic and from the tubercular infection perspective. I think if we say in general, the no age and no sex is immune. Tuberculosis or pyogenic can occur in any age and can occur in any sex. But yes, it has been seen that pyogenic infections they are generally more found in men and certainly more in males beyond 50 years. However, if there are certain immune compromised situations, then it can reactivate, it can occur in any age group. It could be, say, person is IV drug abuser, or person is elderly, person has HIV, or patient is diabetic, or patient has malnutrition, patient has malignancy, or a patient has already on some immune suppressant drug in view of organ transplant, or patient already have some metal implant in the body. Now, these are certain situations where the chances of pyogenic infections are little more than the other population, because in day-to-day activity, every day there is a bacteria reaches into the circulation. You brush your teeth, the bacteria reaches into the circulation. But if there are predisposing conditions, if there are certain predisposing conditions, then the chances of developing a proper spinal infections are more, pyogenic infections are more. Now, as far as tuberculosis is concerned, I think we have already discussed that, because tuberculosis never occurs at the same time. It is always following a bacteria which is lying dormant somewhere in the body as a result of primary complex or as a result of healed old pulmonary tuberculosis. Now that bacteria is lying dormant, and now that bacteria may start multiplying. If someone has all immune compromised situations, they are more prone. And that is how these are certain risk factors where we need to really look for, we need to be little more careful while evaluating some of these symptomatic patients.
Thank you, Professor Anil Jain. The risk factors that you have pointed out could be summarized as previous spine surgery, distant infectious focus, for those who use intravenous drug use. But as mentioned, those with immunosuppression also are especially at risk to spinal infection. So people with diabetes mellitus, advanced age, HIV infection, history of cancer, rheumatological diseases, liver cirrhosis, or renal failure. These are people where the resistance is compromised, and these people are especially at risk. And also for surgical site infection, there can be modifiable and non-modifiable risk factors. Modifiable risk factors include obesity, smoking, malnutrition, administration of antibiotics, extended hospitalization. And the non-modifiable risk factors, of course, are advanced age, immunosuppression, urgent surgical need, diabetes mellitus, or revision spine surgery. Now, There's a question in the chat box, and we'll come to that subsequently. But Dr. CHHITIJ Chaudhary, which part of the spine is most commonly involved? Professor Anil Jain talked about the various parts of the spine which can be involved, but we also know that you have the cervical, thoracic, lumbar, sacral spine. So which part of the spine is most commonly involved, whether it's by region or the part of the spine? Over to you, Dr. CHHITIJ Chaudhary.
So by far the most common site of the spine is the thoracic spine. The thoracic spine is the upper back region in your spine versus the lower back region, where the most common back pain people experience. But it's the upper back region of the thoracic spine where the most common site for spinal tuberculosis you will find. But as opposed to patients with pyogenic infections like bacterial infections, for some reason the lower back seems to be the more common site of infection. And you know, we do see a lot of post surgical or post procedural spinal infections that may count for a significant percentage of this number being in the lower back, because more procedures are being done for the lower back. But by far the thoracic spine is the more common area for tuberculosis by just the sheer volume, because there are more vertebrae in the thoracic spine, 12 vertebrae in the thoracic spine versus 5 vertebrae in the lumbar spine. So if you have the tuberculous bacteria spreading, and maybe it is just proximity to the lung, we don't know, but still thoracic spine seems to be the most common site of spinal tuberculosis. As to the which part of the spine is involved in infection, you can look at the spine grossly in two parts. One is the part of the spine that is in the front of the spinal cord, and the part that is in the back of the spinal cord. So back of the spinal cord is behind, and the front of the back of the spine is the part that is behind the spinal cord, and the front part of the spine is the part of the spine that is in front of the spinal cord. So far majority of spine infections, when they are involving the spine, are in the front of the spinal cord. So that what we call as the anterior part of the spine, the vertebral bodies and the disc, rather than the smaller bones that are there at the back of the spine. So I hope that answers the question.
Yeah, that answers it very well, Dr. CHHITIJ. Dr. CHHITIJ brought it out. We have to know and differentiate between pyogenic tuberculosis and pyogenic infections and tubercular infections. And he brought it out very well that pyogenic infections may be more common in the lumbar spine, but tubercular infections are more common in the thoracic spine. And as Professor Anil Jain also brought it out previously, the infection can be in the disc, which is common in children, more common in children, or could be in the body of the vertebra, more common in adults. But a spondylodiscitis, that is disc and adjacent vertebral body, is the most common form of infections. But it could also be in the covering of the spinal cord, that is dura, so we call that an epidural abscess, or sometimes the spinal cord directly may be involved, that is myelitis. Varis ji had put it in the chat box. Varis ji, we had this question coming, and hence we had not taken your question earlier. Professor Anil Jain, what is the clinical presentation of spinal infections? So that is the question.
Yeah, any infective process in the body, and for that matter, anywhere, whenever this process starts, the first symptom patient experiences pain. Pain. Now, this pain, as in term or relation to the spinal cord, if the cervical spine, neck, vertebral bodies are affected, then pain in the neck. If the thoracic spine or the dorsal spine is affected, then pain in the upper back. And if lumbar spine, then pain in the lower back. Now, this pain may be associated with fever. Now, speed or increment in the pain in few days' time, and as well as worsening of pain in the night, worsening more in the night, that suggests that we are dealing with some infection which is by aggressive bacteria like pyogenic bacteria. Now, if a grumbling, slow pain coming up over certain weeks, and to begin with, it may not, it is improved with the rest, but later on, the night pain may also come in, then it might be an indication of a nature of infection which is slow, like tuberculosis, like fungal, any other thing. Now, besides these two pain, the other symptoms could be if along with the disease, the neural component is also been added. As if a nerve root is stimulated, then one may get a pain along the area of distribution of root, that nerve root. So if cervical spine, neck is affected, one may have pain which is in the back and radiating to the upper limb, or pain in the mid back radiating to the chest, or pain in the lower back radiating to the lower limb. Or it may even have motor weakness or sensory weakness coming up. Now, the speed with which these things they start appearing, that gives an indirect indication of type of infection, whether it is a pyogenic or it is a tubercular. So that is one symptom, that is pain without fever, with fever, and patient not feeling well. These are the general clinical presentations. Now, when a clinician starts looking at it, what he tries to find out whether, besides the point I have suggested, locally one may get locally a spine tenderness. If you touch the spine, part of the spine, and pain is elicited, then it means this area is tender, or muscles are little swollen or little in spasm. So these all give us an indirect idea about the area of spine being affected. In due course of time, like in tuberculosis, if it's still not been reported to us, then these patients may come up with some deformity, prominence of the back of the spine, that what we call it is a kyphotic deformity, or some other deformity, sideward deformity, which is little uncommon, but yes, they may do occur, then maybe a kyphoscoliosis. So the spinal deformity may add up. The speed with which this all are occurring becomes an indirect indicator whether they are pyogenic, likely to be pyogenic, or likely to be tubercular.
Thank you, Professor Anil Jain. There is a question in the chat box. Navalananji wants to know that you have tried to distinguish between pyogenic and tubercular infections. But how does one know, how does one have a suspicion of having a fungal infection? So what are the pointers to?
I don't think we can have a clinical suspicion of fungal infection just on a clinical basis. It will remain in the differential diagnosis of all granulomatous diseases.
Thank you.
That has to be proven subsequently by the tissue.
Thank you, Dr. Anil Jain. Navalananji, I hope you got your answer for this. Professor Anil Jain has brought out beautifully the signs and symptoms, but one should understand that diagnosis is generally difficult because the symptoms may not be very typical, and thus it requires a high level of suspicion. So he brought it out that there could be non-specific pain, typically even at rest and worse at night. Fever is there in about 48% of patients with pyogenic spondylodiscitis and 17% of patients with tubercular spondylitis cases. In people with tuberculosis, we say that they may have malaise. So that is a generalized feeling of discomfort, lack of well-being. And there could be also loss of appetite and weight loss. Dr. Komal Kamra has also brought this out in the chat box. And once the pressure within the spinal cord or the nerves build up, there can be also weakness, numbness, or incontinence. These are signs of neurological deficit. That is like a red flag, but it depends on the amount of weakness which may be there. So I hope this comes out very clear, because we should try to understand that if there are these red flags along with back or neck pain, one should get oneself immediately evaluated so that this infection can be nipped in the bud. Coming to you again, Professor Anil Jain, which investigations are done when infection is suspected clinically? And also, what is the role of biopsy in a spinal infection? Why is it important?
I think it is, as it has been brought out a few minutes ago, that our diagnosis depends on high index of suspicion, so that we are able to make an early diagnosis and the delay in diagnosis is avoided. Because the delay in diagnosis is catastrophic in terms of a pyogenic infection, and in terms of spinal infections, it is deforming, spinal deformity and paraplegia may come in. And that is why it's very important that we have a high index of suspicion, particularly identifying possible risk factor in that very patient. Now, having said that, no way we can suspect it, but we have to ascertain the diagnosis. And diagnosis, ascertain, we need certain investigations. Well, blood test, customary, it is done and they are useful. Blood test in pyogenic may be more useful with the increased total count, or maybe alarming rise in the CRP and ESR. However, one ESR alone may not be enough. We need to have rise of total count and CRP that is supportive of a pyogenic infection. That is not diagnostic. Now, then we go for imaging. Imaging is the key. And for that, in the first imaging, plain X-rays, which may be non-contributed in early symptom period. But still, they are to be done because they are subsequent treatment, they are useful. MRI becomes the gold standard for all such cases where there is a persistent localized pain of a shorter duration with a high index of suspicion for pyogenic, or a persistent localized back pain of a longer duration for tubercular, which is grumbling. So MRI becomes the gold standard to ascertain a diagnosis. And if we cannot do an MRI for certain contraindications, then CT or radionuclide imaging is done. Now, even those imaging can tell us, localize the disease area, can tell us some, suggest about the type of affection, but it is the biopsy, it is the tissue that can differentiate all kind of infections which we have just enumerated. And that is why we try to do a percutaneous biopsy in terms of a CT-guided biopsy, or else if, and most of the time in a good percentage of cases, this percutaneous biopsy is pretty useful and pretty useful to ascertain a diagnosis. Now, the most important things comes that you have taken a CT-guided biopsy, what to do with it? I think you have to submit that tissue for gram staining and pyogenic culture. You have to submit that tissue for all investigations for tuberculosis, AFB smear, AFB culture, molecular method, CBNAT, and histology. Now, these all put together, in most of these instances, we are able to ascertain whether we are dealing with a pyogenic infection or we are dealing with a tubercular infection. Now, so by this tissue, we make every possible effort to reach to a diagnosis. Now, one thing more, if we are suspecting pyogenic infection, then it is good idea to give, at least send 1 or 2 blood culture before starting an antibiotic. And even if 1 or 2 dose antibiotic is being given, even then it is useful to get a blood culture. Now, once this all been done and we have been able to, still not been able to sometime ascertain because that tissue by percutaneous method was not enough, then maybe we have to resort to an open biopsy sometime. Or else there is an indication, urgent indication of surgery, and we are operating for urgent indication of surgery, then we can defer this open biopsy, because in any case, for urgent indication of surgery, we will procure enough tissue to get the final diagnosis. And that is how we should proceed ahead. It's important that we make a robust, clear diagnosis, because we have to give a targeted therapy against the microorganism. If it is a pyogenic, then good antibiotics which are sensitive, the organism is sensitive to, or tubercular, then we have to give ATT. Unless we give targeted antibiotic, we are not able to stop the progression of disease. And that is why it's important to make a robust and sound diagnosis by taking good amount of tissue.
Thank you, Professor Anil Jain. This has come out very clear to everyone. Now, as Professor Anil Jain pointed out, that we should do blood tests, which includes total WBC count, ESR, C-reactive protein, etc. But blood and urine culture is also very important, because a high percentage of people who have a pyogenic tuberculosis, pyogenic infection, will have blood culture also positive. He brought out that X-rays help assess destruction of the bone and stability, but you won't see many changes in early cases. MRI thus remains the gold standard with a high sensitivity and specificity. Sometimes you may need a contrast study to differentiate from degenerative and tumor lesions. CT helps in assessing the bony changes, including early changes of vertebral end plates in some special cases. And PET scan is reserved for cases of uncertain diagnosis or when MRI is inconclusive per se. So, as Professor Jain brought it out, that you can come to a definite diagnosis only by a biopsy. So, which could be done by a percutaneous CT-guided biopsy or C-arm-guided biopsy in the operation theater. And we should send the specimen for evaluation of all the types of infections that we have discussed before, and that has been very well brought out. So, in pyogenic spinal infections, when clinical symptoms and imaging are typical for vertebral osteomyelitis or infections, and blood cultures are positive for a common pathogen such as Staph aureus, a needle biopsy may not be required. But in all other cases, biopsy and culture sensitivity is advisable. In cases of critically ill patients which have a septicemia, that is where the infection has spread throughout the body, an empirical antibiotic therapy should be started promptly without any delay. And in cases of negative blood cultures with 2 consecutive negative needle biopsies, as Professor Anil Jain brought out, an open biopsy would be recommended. Now, again, for spinal tuberculosis, growth of the tubercular bacteria, that is mycobacteria, in culture specimens is the single most confirmatory diagnosis and is considered the gold standard. The Index TB guidelines for bone and joint TB assert that in TB endemic areas, it is reasonable to start ATT in patients with strong clinical and radiological evidence of tuberculosis of spine and monitor their progress. However, where possible, all patients should have a biopsy of the lesion to provide a specimen for culture to confirm the diagnosis and perform drug susceptibility testing. This becomes all the more important because of emergence of multi-drug resistance, so which you can come to know only through the culture. So we talked about the importance of having a roll-up biopsy in tuberculosis per se. Now, Dr. Kshitij, what are the goals of treatment in a spinal infection? Now, there was an era when people with tuberculosis used to be put in the sanatorium. Then the management was revolutionized with chemotherapy for tuberculosis. So, with the evolution in time, have the goals of treatment evolved? So over to you, Dr. Kshitij.
Yeah, that's a good question. And a lot of changed after the antibiotic era. If you see, when we had good antibiotics, we had a very powerful tool in our hands to cure a person of an infection. Targeted antibiotics, whether they are specific for tuberculosis, fungus, or for pyogenic bacterial infections, but the antibiotics have made a big difference in cure. Obviously, the goal of treatment is cure, resolving the infection, getting rid of the bone infection in the spine. That is the end point of treatment. But over a period of time, as the other treatments, associated treatments have evolved with it, now we kind of have higher standards, right? We don't want the patient to suffer from all the negative consequences that an infection will bring on when it affects the spine. And when we look at what the infection does to the spine, there are basically two things that we are looking at. One is an injury to the spinal cord, which would result with neurological weakness and paralysis in the legs. And the second thing, second consequence is a deformity, where the infection eats away the bone so much that the spine is no longer supporting the weight of the patient, and it completely bends and collapses over and creates a very ugly deformity that itself can be damaging to the spinal cord. But a loss of column or the supportive structure, that's the main important function of the spine, is lost. So although you can get rid of the spinal infection with antibiotics, these are the two things which are the bad things that can happen to the spine because of an infection, where antibiotics are not generally going to help you if you are going to have paralysis. That requires a surgical treatment. So over a period of time, we have gotten more aggressive with these infections when they do cause complications. Complications such as paralysis and spinal deformity, where the end point of our goal is to give the patient a normal spine which has a normal function with respect to neurology as well as deformity, even though the infection is being cured by the antibiotics.
So great, Dr. Kshitij, brought out very well by you the goals of treatment and how they have evolved with time. Just to reinforce what Dr. Kshitij brought out, we should strive to have an early definitive diagnosis, eradicate the infection, a relief of the back pain or neck pain, prevention or reversal of any neurological deficit, preserve spine stability, and correct any spinal deformity if it is there. In fact, prevention of spinal deformity is very important. So, goals of surgical treatment are early decompression of the spine and stabilization of the involved spine, especially if there is a neurological deficit, aggressive tissue debridement, including drainage of any paravertebral abscess, and sample harvesting for microbiological and histological analysis. Of course, pointing it out that the surgery may not be required in all cases. So, as Dr. Kshitij brought it out very well, so there was an era when there were no drug treatment for tuberculosis. People used to be sent to sanatorium, and there was a high mortality rate. So at that time, the goals were reduce the mortality. Then with good drugs being available, there was still morbidity which was associated, like paralysis, etc. So then the goals changed to reduce the morbidity. Now in this era, with a good surgical and conservative management being available, the goals, again, though in emerging countries, remain reducing the morbidity, but reducing the deformity has become a major goal, because there is destruction of the spinal vertebrae, and that can lead to deformity. So, and that can lead to later complications other than the cosmetic issue which is there, as you can see in this boy here. And so that has become a major goal subsequently. Now, Professor Anil Jain, there are two questions in the chat box. I will request you to quickly answer them because they pertain directly to what you had discussed regarding the investigations which are done and evaluation that we do for spinal infections. So Navala Anandji wants to know that is there no other way to diagnose a fungal infection other than doing a biopsy, that is through histopathology? Is there any other way that you can try to confirm fungal infection? Or so I think you have answered that before, but you could just reinforce.
I think probably this histology is the most important and is the method to ascertain diagnosis of fungal osteomyelitis.
Yeah, and the other question which Dr. Komal is asking is, when you do a biopsy, right, it's not always possible to differentiate between an infection and say a tumor or a cancerous lesion, especially in the elderly. So if you do a biopsy, is there a chance that the cancer may spread due to the biopsy?
Generally, what has been my experience, that if I am subjecting a patient with a clinical imaging diagnosis of tuberculosis, most of the time by tissue we are able to ascertain it to be tuberculosis. Now, even for tumorous, I think that is the easiest way to get a quick diagnosis without disrupting the lesion. So I don't think it has any disadvantage to and most of the advantage that we can have a percutaneous tissue for biopsy.
Yeah, also important to point out, Komalji, that even in spinal carcinoma, we resort on a biopsy to plan the treatment. So there are ways and means wherein we can prevent the spread of the cancer per se. So that remains a very useful tool as such. Professor Anil Jain, will come to the next question, which is there. What is the non-operative management? In fact, non-operative should not be construed as indicating otherwise. It is the most important treatment that we have. What is the conservative management of spinal infections?
I think, again, here I would like to discuss this in terms of a diagnosis with a pyogenic infection. Now, in that case, I would like to first give targeted antibiotics, providing rest for few days till the spasm and pain permits, and then mobilize with supportive braces. And generally, gradually, we keep on monitoring the patients that they gradually improve in their spinal stability, and we can even prevent neural dysfunction. So that is how we treat most of the time conservative or non-operative methods. However, for tubercular, I think we need to evaluate the lesion in terms of spinal instability. And if we are sure that patient does not have a global disease where body and posterior complex is disease, patient doesn't have a very long segment disease, then we believe in putting on full targeted full course of ATT with supportive braces depending on each segment of spine. And then we start mobilization, in-house mobilization, or what is called as ambulant chemotherapy. But we need to identify the imaging features of spinal instability, impending spinal instability in that patient, so that the risk of neural deterioration can be avoided. But yes, good number of patients with a short segment tubercular disease, we do treat them with a conservative or non-operative methods. I will not call it conservative, I will call it non-operative methods.
Thank you, Dr. Anil Jain, for pointing that out. That assumes also importance, because this very often you would, even if you go in for surgical management, you would need to retain the drug treatment and the treatment that you have mentioned. So the indications would be absence of neurological deficits or minor deficits, absence of spine instability or absence of intractable pain, and If it is a bacterial infection, treatment is done with antibiotics after definitive diagnosis. If there is sepsis or a definitive diagnosis is difficult, as we mentioned before, an empirical antibiotic therapy could be given. But this antibiotic treatment generally continues for a long time. So it is generally injectable for 3 to 8 weeks, followed by oral antibiotics for a while per se. Now, on the other hand, if it is tuberculosis, the anti-tubercular therapy continues for a longer duration. So you have various regimens available, but the general regimen is the 4-drug therapy for 2 months, followed by a 2-drug therapy for 7 to 10 months. This is easily available at all government centers free of cost. And the discontinuation of treatment is done after the...
Dr. Chhabra, I'd just like to intervene on the previous slide.
Sure.
Current dosage regimen includes 4-drug therapy for 2 months, followed by rifampicin, INH, and ethambutol for full maintenance phase. And the reason being that now there are enough proof that we have documented 16% drug resistance against INH. And that is why 3-drug regimen is given at all government centers also, and that is the prescribed. Now, the only point which is not available in the text, we have to be watchful for ethambutol-induced toxicity. So every 6 months onward, we need to get a fundus examination and field charting and ask the patient, is he finding it difficult to in the vision clarity? In that case, we need to stop ethambutol and add another drug that is levofloxacin. But that has not yet come as the number of cases. They are now being reported as isolated cases.
Yeah, thanks, Professor Anil Jain, for adding that useful information. And after a stipulated period, one would stop ATT if everything is fine. Professor Anil Jain also talked about the role of immobilization in such cases. So we will move further and we'll come to Dr. KSHITIJ Chaudhary. Dr. KSHITIJ Chaudhary, when is the surgery indicated for spinal infections, and what is the normal surgical management that is done?
So now the reasons for doing surgery are different for different kinds of infection. So the commonest infection is tuberculosis. So when we are choosing surgery for spinal tuberculosis patients, essentially we are doing surgery for the complications of spinal tuberculosis infection. So which means that most of the time spinal tuberculosis can be treated with without surgery, as it's more of a medical disease. But the complications essentially can happen. You can say the negative effects of spinal tuberculosis on the spine rather than complications are either an injury to the spinal cord or a sort of anticipation that this spinal column is going to get damaged far beyond and cause a deformity. So if there is a neurological deficit where a patient is not able to walk or function normally, then usually it is surgical treatment. And the second reason is an anticipation of deformity. Let's say the spine is damaged so much that we anticipate that the end of the treatment is the deformity is going to be significant. Then it is easier to do surgery when the infection is active than to correct a spinal deformity when the infection has healed. So this anticipation requires a little bit of kind of judgment, or sometimes that anticipation comes after judging serial X-rays. That means we are taking X-rays of the patient and then we are seeing more and more destruction. Although the patient is getting better in terms of infection, but we see that the column is collapsing, the column is changing shape, more vertebral bodies, the collapse is happening, and the end result is going to be bad. Then we would intervene surgically at that point in time, because it's easier to do surgery when the disease is so-called wet tuberculosis rather than when it has healed. The other reasons for doing surgery essentially come down to if the antibiotic treatment is not working. Like, there is not good response to the antibiotic. We expect the infection to have healed or show at least healing response. We don't know what is going on. The biopsies have turned out to be inconclusive, and overall there is a doubt regarding what is happening. Then yes, surgical debridement is the treatment if there is not good enough response to medical line of treatment, which generally takes a few months. It's not something that happens overnight or within few days. The other reason for doing surgery in spinal tuberculosis is if you develop instability, which means that instability is a little different than deformity. Instability means that there is some like movement that is happening in the spine and that area has not healed. So every time the patient walks, stands, bends, there is a small few millimeter angulation that is happening in the spine, which causes pain. So essentially, sometimes you are treating the sequelae of spinal tuberculosis in terms of instability that is causing pain to a patient, and there you may do surgery for those kind of patients. Whereas if you look at, these would be the most common reasons for doing surgery in spinal tuberculosis. But whereas if you have pyogenic infections, then you are more aggressive with the surgical line of treatment, because pyogenic infection by itself is aggressive. So if somebody has pus, like the kind of pus that you sometimes develop like boils that is there, imagine having a boil or an acute infection because of bacteria right next to the spinal cord. That needs to be evacuated ASAP. So many times the surgical debridement for like say staphylococcal infections or aggressive pyogenic infection is surgical debridement on day one and then cover them with antibiotics, because with these pyogenic infections, these antibiotics don't reach very well, and surgery generally helps the antibiotics get rid of the or resolve the infection. So in general, these are the broad principles where we kind of do surgery. So to summarize, tuberculosis surgery is uncommon if you detect them early and you don't have any problems associated with spinal tuberculosis, such as neurological deficit or an anticipated bad deformity. Then you are treating them with antibiotics. You do surgery for healed tuberculosis when bad things have already happened. And for pyogenic infection, in contrast, you are more aggressive with surgery because the infection tends to be more aggressive, happens in sicker patients. Antibiotics by itself are lesser effective. So the indications for doing surgery is much, much earlier for pyogenic infections than tuberculosis infection. I hope that answers the question.
Very well, Kshitij answers very well. We have a question on Facebook Live from Anil Kaushalji, who wants to know whether the pain in lower back has anything to do with CKD. Now, chronic kidney disease can lead to issues with osteomalacia and osteoporosis. So the bones get weak, and that can result with back pain as well. Also, in chronic kidney disease, if there is that leads to a sedentary lifestyle, that can also predispose to back pain per se. And also the risk to a spinal infection also increase per se. So that's a relevant question. I will, before moving forward, I will ask Professor Anil Jain two very brief questions which are there in the chat box. One is Komalji wants to ask Professor Jain, would external brace helps in reducing the chances of deformity?
I think brace, they are not given to prevent, correct the deformity. But yes, bones are mechanically weak. It's very painful and spasm. So we support the spine depending on the segment of the spine affected. If it is cervical spine, so maybe a four-post collar or a soft collar. If a dorsal spine or a lumbar spine, an ash brace or a lumbosacral brace or Taylor's brace. So that kind of braces are being imparted so that mechanical stress on the diseased vertebral body can be minimized and muscles while advocating an ambulant chemotherapy.
Thank you, Dr. Anjan. The other question, which is from Dr. Gaines, what is the duration of treatment in multi-drug resistant tuberculosis? Does it differ from non-resistant?
I think again, multi-drug resistance is altogether a new disease entity. And as Dr. CHHABRA has shown one of the slide, these were the criteria which has been listed in the index TB guidelines also. And on those basis, we suspect failure of treatment. And I think that was the first time I published in 2012 as a criteria. And we have tested those criteria. They are very reliable criteria. And in most of these patients, our effort is to ascertain drug resistance by debriding the lesion, submitting for culture and molecular method. By molecular method, CBNAT, in 48 hours, you are able to tell rifampicin resistance against rifampicin, and by LPA in about 2 days time about rifampicin and INH, and rest by culture you can get it. Now, once you have defined the culture drug resistance, then again targeted therapy is now being advocated for drug resistance tuberculosis. There was a regimen given for 18 months to 24 months, but now some of the newer drugs have come up, newer regimen have come up, and there are every efforts to customize those drug resistance treatment to 12 months or even attempt to less, because some new drugs are being added. And that is how the drug resistance is being given, by giving a tailored, customized ATT regimen.
Thanks, Dr. Anil Jain. Could you also respond to the next question, though Kshitij has referred to that partially? What is the post-operative management of spinal infections?
I think, as we said, that we have operated a spine, suppose we have stabilized and whatever has been done. Now, the core issue of management remains the medical therapy. You have to ensure that medical therapy is given properly. You have to give a good nutritious diet. You have to ensure that you give some vitamin D and calcium as well. Besides that, spine needs to be protected based on, if suppose you have operated for paraplegia, then you have to assess when the neurology allows the mobilization of patient. Otherwise, you have to treat it as a paraplegic patient. If there is no neural deficit, you have operated for deformity, then depending on the deformity, how your stability at the spine has been achieved, and then you have to mobilize the patients as per the suitable orthosis. So that is how we advocate post-operative treatment.
Thank you, Dr. Anil Jain. Now we will move on, and you have brought it out very well. Before that, Dr. Kshitij had brought out the indications for surgery for spinal infections, which could be either if there is motor weakness, that is loss of muscle power, sensory loss, or bladder bowel involvement, or if the spine becomes unstable, or if there is a deformity which is coming, or severe pain, or there is epidural collection in cervical and thoracic region. You also pointed out that in conservative, in post-operative management, you would continue with the antibiotics for the stipulated duration. You would monitor clinical recovery, and also liver function tests needs to be monitored with any antitubercular treatment. If needed, there would be repeat radiology. And generally, one should be aware that radiological recovery lags behind clinical recovery per se. Moving on to the next question, which we will pose to Dr. Kshitij. what are the complications or consequences of spine infection? This has been partially discussed, but in order to reinforce and for all of our participants to be aware about it, Kshitij, could you throw more light on that?
Yeah. So the major complications or problems with spinal infection, so again, you divide them into tuberculosis and pyogenic grossly. We won't consider the rarer ones, but you can put the rarer ones in pyogenic itself. And the primary thing is, dying because of this infection. Mortality rates for spinal tuberculosis have drastically come down, but this emergence of drug-resistant tuberculosis has brought that question back again. Hello, can you hear?
Please go on.
Yeah. So, mortality or dying because of tuberculosis infection, we are now kind of seeing that back again because as Dr. Anil Jain just said, that's a different kind of disease we are dealing with. And in the future, our country will have to deal with more and more of these drug-resistant cases where we have to really find ingenious ways of creating newer antibiotics to chase this down. So until we kind of peg this down to getting better antibiotics, better protocols in place, and in general treating the root cause of tuberculosis, which generally is related to the standard of living of our country, until that happens, we are going to keep having these kind of dangerous infections. So mortality rate is one of the problems, especially with drug-resistant tuberculosis and the multi-drug resistant and the extreme drug-resistant tuberculosis. And for pyogenic infection, especially in the sicker patients who are on dialysis, immunocompromised, and have other problems, getting a bacterial infection can lead to death in about 15% of patients. And again, depends on the severity and underlying medical conditions of these patients. But apart from this kind of a morbid outcome of spinal infections, most spinal infections nowadays with modern treatment can resolve without complications. The other complication, as we discussed, is neurological deficit. And let me bring about one primary difference between neurological deficit that happens with spinal tuberculosis versus neurological deficit that happens because of pyogenic infections. Neurological deficit because of tuberculosis infection generally recovers with surgery or antibiotics. But if you develop paralysis or complete neurological loss because of a epidural abscess because of a pyogenic infection, say Staphylococcus aureus, then the chances of neurological recovery are very, very low unless you operate them immediately. So it's kind of a surgical emergency to evacuate epidural abscesses that are because of pyogenic infection. And then the second other complication that we see with spinal infection, which we see more often with spinal tuberculosis, is the deformity that can happen because of an excessive bone damage. We don't see that so often in pyogenic infection because pyogenic infection, by the time it will damage the vertebral bodies enough to cause a bad deformity, the patient will have such severe toxic sepsis because of that he won't survive, he or she won't survive. So that's why we see bad deformities in slow grumbling infections that over a period of time damage bone versus worse neurological deficits that are very difficult to recover from in pyogenic infections. So these are, in short, what all the bad things that can happen because of spinal infections.
Thank you, Dr. Kshitij. We know that there can be not only morbidity, but also mortality due to spinal infections. And that's why it is important to know about it. So you have covered very well how neurological deficit, deformity, back-end radicular pain, which persists later, and sometimes the infection spreading throughout the body, resulting in sepsis and also a mortality rate, as we have previously pointed out. These indicate that we should do timely treatment. The next question is to Dr. Anil Jain. We are coming towards the end of the webinar, but we have a couple of quick questions. Which group of patients need special considerations for management of spinal infections and why?
I think this is a very important, pertinent question at the end of webinar. To my mind, all patients, whether children, whether elderly, whether immunocompromised, to my mind, all patients, they need special care, special consideration in terms of making an early diagnosis, particularly a pyogenic infection if we suspect, so that we intervenes early and patient does not develop a neural deficit. Because here the neural deficit is a vascular insult to the spinal cord. Now, having said that, these patients of elderly immunocompromised, they, for any infection, whether it is tubercular, whether it is pyogenic, they are the one where we need to keep our suspicion index very high to suspect pyogenic infections very early, because tubercular infection is can allow us some delay, but pyogenic infection cannot allow some delay. Now, I would certainly like to make a very specific remark here, because these elderly immunocompromised patients, they generally have a less symptom because their inflammation is lesser in comparison to normal persons. And that is why their symptomatology is of low magnitude. If you get a blood investigation, anything else, you may have less chance of getting anything positive out of it. And that is why it is yearly suspicion index that takes you to put the patient to get a MRI done and all other investigation to make a diagnosis. Similarly, children, small children, particularly tuberculosis, having a grumbling pain, child is playful, not communicating, not telling, able to tell the patients about the pain. And if the diagnosis is delayed, the deformity and damage, destruction to bone is very fast, because these are all cartilage bones. These are not solid bones, and they are destroyed by inflammation very fast. And that is why these category where we need to have our suspicion index very high to make an early diagnosis. And similarly, even if you have diagnosed, say for example, elderly, you have, or patients already on immunocompromised, or maybe patient who already have undergone transplant. Now here, even while treating these patients, if you make a delayed diagnosis and if they are put to the bed rest for certain time, then their chances of post-treatment, other organ complications, in having an other system involvement, they become increased, like deep vein thrombosis, like appearance of a decubitus ulcers, like some chest infections, like recurrent urinary infection. And that is why we have to be very attentive in making a diagnosis early in immune-compromised patient and treating them aggressively.
So thank you, Dr. Anil Jain. This has been brought out very well, and I hope everyone has understood it very well, that there are special considerations for the elderly and for the children. And in children especially, we need to start the treatment early, and especially since they have growth potential, delay in treatment can lead to a progressive spinal deformity and early or late onset neurological complications. And also in the immunocompromised who are at special risk of developing spinal infection and multi-drug resistance, a high index of suspicion should be maintained per se. Kshitij, why is timely and proper management of spinal infections very important? This is a very important message, again, for all the participants. What happens if we do not do timely and proper management?
Yeah, so that's a very important point that you bring out with this question. Uh, infections, when they are picked up on time and treated the right way, will almost have no negative effect on the spine. The bone will heal completely and it will become as it was before if it is treated on time. So the primary reason for early diagnosis and treatment, and sometimes it's hard to make an early diagnosis in some cases, but early as possible, and for that you require a high degree of suspicion, especially if you live in an endemic country like ours. And when we try to apply these rules that Western literature and guidelines tell us about low back pain and back pain patients, and how most of the back pain that we deal with is benign. But you'll be surprised how many spinal tuberculosis patients present almost similar to benign back pain. They don't have nighttime pain. They don't have, like, I recently had a patient who ran the marathon, the Mumbai marathon, and a week later was diagnosed with such huge psoas abscess and spondylodiscitis, and he was relatively fine. And the only reason why he came to the hospital, because he thought that maybe he injured himself during the marathon. And he ran the marathon with that spinal tuberculosis in his spine. So when we are seeing patients who complain of this grumbling sort of pain over a long period of time, especially in our country, we are suspecting, keeping this diagnosis at the back of their mind, especially if they have pain in the upper back region. Like I told before, that upper back region spinal tuberculosis is more common than lower back region, and that is an unusual area to have a little bit of a grumbling sort of chronic pain over a period of time. So having a high degree of suspicion in our country, and even for patients who are not those typical patients who are whom you think would get tuberculosis. You know, Dr. Anil Jain said that any person can get spinal tuberculosis, whether they live in penthouses in Mumbai or they are from slums of Mumbai. Anybody can get spinal tuberculosis. So that's why we can't have this kind of a differential investigative protocol for somebody whom we think is high risk for getting these infections. And this is the only way to pick them early. Fortunately, MRIs and these investigations are now easy to do, although they are slightly expensive, but have a degree of suspicion for them, diagnose them early, because if you can do that, you can treat these patients without any surgery, without having any negative consequences of deformity and damage to the bones. I hope that answers the question.
Very well, Kshitij. We also delved on this at the start of the webinar, that it's important to start the treatment timely. Otherwise, there can be serious consequences, as Kshitij has brought out, and also a high index of suspicion, because there can be a non-specific clinical presentation per se. And timely treatment has brought down the mortality rate substantially, and this becomes all the more important if there is a neurological deficit that you need to intervene early. Improper treatment has contributed towards emergence of multi-drug resistant spinal infections, and so we need to have proper treatment. And it's important for all of us to be aware that if you have spinal infection, undergo proper treatment with the right antimicrobials, with good quality medications stored properly, and do not interrupt the treatment prematurely. So they say, and it is well accepted, that prevention is better than cure. So probably a very important question at the end of the webinar to Dr. Anil Jain. Dr. Anil Jain, how can one try and prevent spinal infections?
I think it's very difficult to work for activities for prevention of spinal infection in isolation. But yes, to my mind, maintain yourself physically active, be nutritionally good so that you don't have an immune compromise because of malnutrition. Malnutrition does not mean poorly fed or well fed. Malnutrition may be in a well-fed population also, because where the protein and all those intake are not proper. So maintain physical health, maintain your nutrition, have an early suspicion in if someone has a risk factor. If you have a risk factor, whether someone has a cirrhosis or someone has a malignancy, or someone has been treated with orthopedic implants, or someone has diabetic, or someone has a HIV positive, then these all risk factors patient, we need to have a early suspicion to reach to the clinician, and clinician has to have an early suspicion to diagnose them. Any pain, persistent localized pain for 6 weeks or more in anyone, whether well-fed or underfed, needs investigation for a tubercular lesion. And any persistent localized pain, shorter duration with fever and all those, that needs a clear look for spinal infections. That's my take on prevention.
So this is very important, whatever Professor Anil Jain has mentioned, because we can try to prevent and do everything to try to reduce this morbid condition. Those who are immunocompromised need to take special precautions, and this holds true for all people at risk. They should try to control their risk factors and try to ensure that they do not develop the infection and have a high index of suspicion. But it is well accepted that an approach towards generalized well-being will try to prevent infections. So what does that entail? Simple rules: hand washing, balanced diet, regular exercise, optimum sleep, quit smoking, avoid alcohol. And friends, this is a snapshot directly from the Center of Disease Control and Prevention. So we should have a healthy lifestyle in a nutshell, and with that we can try to reduce the chances of spinal infection. So I think with that, I would request each of our panelists, Dr. Anil Jain first, and then Dr. KSHITIJ, to conclude with what their carry-home message would be for the participants.
I think I've already said that you have to make all efforts to be physically fit. You have all efforts to make yourself nutritionally well-fed, and at the same time, keep a watchful on any events occurring, any untoward symptomatology developing in your body. That's the way to prevent the spinal infection.
Thank you, Dr. Anil Jain. Very important message, Dr. KSHITIJ.
And I have a little bit different take on that, especially for tuberculosis. And obviously, it's extremely important to stay healthy as much as possible, not only for preventing spinal infection, but also for preventing the host other problems that can happen in this long life of ours. But specifically for spinal tuberculosis or tuberculosis in general, this is more of a public health problem. And the reason why it is more problematic in our country is the standard of living. The standard of living, the poverty, the overcrowding. And when we said before that nobody is immune from getting this infection, that is absolutely true. But the overcrowding and the poor sanitary conditions and the slums, it keeps that infection in the population. It keeps that bacteria in the air for even the affluent to get that bacteria from. So eventually, I see, and we are on that trajectory, and India is a growth story. We have been seeing that and hopefully we will achieve that quite soon. But as the standard of the population, living standard of the population increases, we will find lesser and lesser spinal tuberculosis, or for tuberculosis in general, as we live longer, healthier lives in better sanitary conditions, lesser crowding. So tuberculosis is just not something that an individual person can prevent or control. It is more of a thing for our governments, and we as society members of this country can help with. So that is what tuberculosis means to us. That is all that I had to say. Thank you very much.
Thank you, Dr. Kshitij. Of course, a healthy lifestyle is important, but there is a role of each stakeholder in trying to reduce the morbidity and mortality associated. The government, the professionals, the healthcare institutions, and all of us are equally responsible for reducing this morbid condition. So if there are any questions, please write them in the chat box or raise your hand. We have stretched, but I'm sure our very esteemed panelists would stick for a few more minutes to respond to any questions. So the carry-home message, friends, for today's webinar could be there is often a delay in diagnosis of spinal infections, and hence the importance to create awareness about spinal infections so that we can nip it in the bud and take medical attention as early as possible. This comes only with a high index of suspicion. A proper clinical radiological evaluation can clinch the diagnosis, but the ultimate diagnosis is always histopathological. Timely treatment can prevent long-term complications. An optimal treatment includes both appropriate antibiotics for appropriate duration and, if needed, surgery. Aggressive and prolonged treatment along with monitoring is required. It is essential to investigate if red flags present with non-specific back pain. And the red flags include, as has been pointed out, upper back pain or thoracic pain, fever and unexplained weight loss, bladder or bowel dysfunction, ill health or presence of other medical illness, progressive weakness or neurological deficit, disturbed gait, and age of onset less than 20 years or more than 55 years. Friends, this webinar was brought to you by Spine Wellness and Care Foundation, a charitable non-governmental organization established for improving the wellness of people with spinal ailments in India. We reach and serve persons affected with spine-related ailments medically and socially to help them lead better lives. Our main objective is to provide medical, rehabilitation, vocational, recreational, and social support for persons affected with spine and related ailments. You can reach us through the social media or the email, and our details are available on the website per se. And I'm happy to let you know that today's webinar was organized in collaboration with Shri Balaji Action Medical Institute. Our next webinar would be on 11th of August, again on a very important topic, cervical myelopathy, which is one of the most important conditions leading to symptoms in the elderly individuals. Friends, it is in our hands to create a better world for all who live in it. Come join hands to improve spine wellness and care and to alleviate the burden of spine disease. Let's start with ourselves by following a healthy lifestyle, and that is very important in preventing spinal infections and spinal morbidity per se, as was brought out by our esteemed panelists. So thanks to our esteemed panelists for taking out time to create awareness amongst the society. This webinar will be available on Zoom, so people who would want to go through it again or would want their near and dear ones to view it subsequently could see this on Zoom, and the link would be available on our website. Thank you once again for joining the webinar today, and hope you will help in creating awareness on how to reduce the morbidity from this spinal condition. And if there are any last-minute quick comments or questions, we will be able to take them. Please raise your hand and we'll unmute you so that you can pose the question. Again, thanking Professor Anil Jain and Professor KSHITIJ Chaudhary for a very interesting discussion and helping create awareness about this disease. So hope you all have a great weekend. We look forward to seeing you again subsequently in our next webinar or in one of our activities. Thank you.
Thank you.
Thank you.